So regarding the exam, I was telling, bless you, I was telling some of my North Canton students, this exam was very interesting. I had, before analysis, I had a high of 94 and I had a low of 58. So it was a huge, massive difference. And it wasn't just one person in the 90s. I had multiple people in the 90s. And then I had a lot of people in the 70s, some 80s, but I would honestly say the majority, before analysis, the average was a 74. And then after analysis, I think the average was 84. I ended up taking that amiodarone select all that apply off. We absolutely covered it. I'm pretty sure I put it on the key points, but I'm not 100%. Somebody will have to correct me if I'm wrong. But it was worth 3 points, and I think only 0.4%. So like, what would that be? Like 40%. It doesn't say anything about amiodarone. I swear it did on our key points. Anyway, it doesn't matter. I gave it back anyways. So there was a select all with amiodarone, and the answers were to have the patient have their eyes examined because it causes cataracts, pulmonary function tests because it causes fibrosis, and thyroid because it affects your iodine levels. So, and the discrepancy on the question was really poor, so I just ended up giving it back and that made a huge difference for almost every single one of you. I think only one person out of 51 people got that correct. And then like, I think it was like 80% had it partially correct. So I ended up giving that one back. That made a huge difference. I think I gave three questions in total, but it ended up being 5 or 6 points in total that I gave back. So obviously, if you had gotten that question correct, then you already got it correct. That's how the points back work. So if you did not get it correct, there's either two choices that I accept multiple answers. So if you picked another answer that I accepted, then you would get it right. Or if I give all credit to everyone, then it didn't matter what you picked, you would get the point back. So after everything, I believe there was 8 or 9 still under the 76 out of 51 people, which is better than what it was before analysis. So, but it was wild to see like such high percentage, and then also to see it on the other side. So now that we've all taken the exam, how do we feel about, do you feel that you maybe didn't study the things that you should have studied? Is there something that I can do better to like going forward?
I know for a fact I last minute studied.
You last minute studied? I used to do the same thing.
I got the 3 kids, so it gets a little hard. Yeah.
I think it's just a lot of information really fast, which is just how this program is. But now I feel like I'm going to have to retake this course.
Well, so, okay, hear me out.
Well, I mean, you like there is only a I mean, realistically, I have had someone get a 66% on their first exam and still pass my class. And it was because she busted her ass on those last 2 exams. And ended up pulling through. And I was very, 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 very proud. So, is it possible to come back out? Absolutely. If you don't think it's possible and you want to go and you want to like play around with numbers and see kind of where you lie and what you need, then I'm willing to do that for you. Go ahead.
So bowling gave me a tip, and had I did what I was supposed to do, I probably would have did better. But she tells us to help the online, she tells us to copy and paste the week of course objectives. Copy and paste it into ChatGPT and ask them.
Get a study guide?
Yeah, a study guide.
Yeah.
And
Oh, that's a good idea. She said, Dr. Bowling went, I'm assuming when you had her in class.
no, actually, I went to her bawling my eyes out because I suck at taking tests.
Oh, when? This week? Last week?
No.
Oh.
Like 2 months ago.
Oh, okay.
Yeah.
She said that Dr. Bowling said that if you copy and paste the course objectives into chat and then tell it to make you a like advanced pharmacology study guide. And I like the way that you did it where it was like fill in the blank. So you could like go get your own information. And you could even tell it like what book you use. You could tell it everything. You could tell it what book you use. You could even upload PDFs of the PowerPoints. I love chat. I love chat so much that I pay for it.
You can also use Cocoa Notes. I use Cocoa Notes and I upload your YouTube videos and it summarizes it all.
LM too. I add my lectures into Notebook LM and it'll take into account what I said in lecture. I usually do that and I didn't get a chance to do that this week. So it is what it is. Any other feedback from you guys?
So I was gonna just say for anybody that's feeling like defeated, don't. Me and Jessica sat and had meetings after every single exam. Going into the last exam, I was 99% sure I was gonna fail this class. But first of all, don't be afraid to come to her because she's amazing.
Please,
and she's gonna hold your hand and tell you everything's gonna be okay, and she's gonna give you the best advice. And yes, it sucks to fail this class.
Don't
I'm gonna
fuck me
say
up
that.
too much, girl. You're gonna give me a big head.
But she is an amazing resource and she is gonna make you feel better, even though like it's super defeating to fail a class. Like I get it because I did. If you guys need any help, feel free to reach out to me. My email's obviously in the class email. Feel free to reach out to me. I can give you any pointers that I have. I'm happy to work with anybody, send you my notes, whatever will
Study
help.
groups with your people like local to you is also really great. I mean, even if you have to do it on Zoom or like Google Meet or any of those things. I would love for you guys to be able to work together, bounce ideas off of each other. Pharmacology is notoriously a very difficult subject. Cardiac is always the hardest. I'm going to tell you that when we get to complex care also, because we start out with cardiac and it's always, 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 always the hardest. Because not only are we talking about meds, we're also incorporating the disease process, the pathophysiology, the anatomy and physiology, and the treatment of everything. So this week we're going into diuretics and endocrine. And then after that, antivirals and things like that. And then I believe we end with GI. So I will be sending out CPTs probably after class today. For anyone that does not get a CPT, because there's so many of you, we will have to do a group exam review because I can't meet with all 50 of you individually, especially with my mom's service on Saturday. I just can't make it work.
What is a CPT?
It's just too much. A CPT, it's the same thing. It used to be a SAP, the like student academic progress. They renamed it CPT. I don't know why. I don't know why.
If you pass, you don't have to do that, right?
If you passed the exam, you do not have to do a CPT, but the group review is, I mean, it's good for everyone to be a part of, you know, especially for like the final, you know, because this information is going to be on the final. So, okay.
So is it like a
Um,
remediation?
No, it's just me and you just talking about the test.
Oh, okay, cool. Cool. Thank
Yeah.
you.
Yeah, you're welcome.
So are you gonna send like a link for the group one?
Oh yeah, you'll get it in the email. We'll do it on Ring Central. It'll be the same link as Ring Central.
And you said like even if we didn't get under a 70%.
The group review is for everyone.
Oh, okay.
The group review is for, I don't care if you're the person that got a 98%. The group review is for absolutely everyone. Even if you got a CPT, you can still come to the group review.
Okay.
Okay. It is absolutely for everyone. So there are old slides that I used previously that come from Lippincott that like are like come with the book, and those are already on Brightspace. And then the ones that I'm going to teach off of, I put on there today because I just didn't have time to do it before. So I apologize for that.
Hey, Jen,
Yeah.
quick question. I don't know, like when we first started this class, I don't know if I read the. You going based for the book or the ATI book? I thought it said ATI book, but I wasn't sure.
No. I teach from the book,
Okay.
right? But ATI, I do like how ATI clusters things. So like if you go to a certain subject in the ATI book, and you look up, I don't know, heparin. Like instead of giving you 6 pages on heparin, it gives you the most important things on heparin in 1 paragraph. You know what I mean? That's what I really like about ATI. Should it be your only study material? No. Should you use that plus, you know, your PowerPoints in the book? Yes. So, but I like how condensed ATI is just my opinion. So.
Okay. Thank you.
When it comes to labs, sometimes you have conflicting information between like ATI, your book, and blah blah blah. When it comes to that, I usually, especially because you guys are taking tests like proctored exams through ATI, I will use the ATI labs if that were to come up at any point. It doesn't usually come up in farm, sometimes, but mostly in other classes, it'll become like a thing. So, anybody else before we get started?
I have something. We emailed last night, Miss Simmons, about the Lippincott. You had mentioned it in your email, the issues that we were having with Lippincott and about the assignments.
Yeah.
I can't get back into those assignments on Lippincott to finish what wasn't completed.
Yeah, because they're closed because the due date has already passed. I'll have to reopen them.
Yeah. Okay.
Yeah, I'll have to reopen them.
Jess,
Yeah.
so this has nothing to do with like the test or anything, but Mariah
Yeah.
also put it in chat. Thank you so much for the Afrin.
Oh my God, you're
I
welcome.
stopped after the exam and got some because I am dying and I feel like a whole new person. So thank
Do
you.
not use it for more than 3 days. I'm telling you. I will say I have pushed it. I have pushed it to 4 days, but please be very careful because that congestion will come back with a vengeance. So you're welcome.
It really is.
Aspirin-
It's addicting in so many, that congestion, the rebound congestion. But
Yeah.
I was like walking around my house just sniffing everything. I was like, you guys, look.
Aspirin is truly a gift from God. It really, really is. Okay.
What chapter are we starting with?
50.
Thank you.
All right, is my TV gonna work today? What do we think? Definitely don't have a remote. Okay, let me just pull you guys up on my TV here. Not responding, it says. Yay. Okay. Hold on. Okay. Are we ready? Okay, so I mean we went over renal a little bit last week. But this is where we're gonna go over more of like the actual renal tubules, what they do, how diuretics work, and all that fun stuff. So let's do this in like so our kidneys have four really big functions. So number one, we have fluid and composition. And this is maintaining fluid volume, electrolyte balance, and it's extremely precise. The more your kidneys are damaged, the less precise that mechanism is. We have blood pressure regulation, which we talked about last week with the renin-angiotensin-aldosterone system. We have metabolic activation. It regulates vitamin D and supports calcium. And then we also have red blood cell production, which we also talked about last week with erythropoietin. So we did talk about the structures of the kidney, but at least now it's in front of you and you can see it. So the adrenal gland, the adrenal cortex sits right on top of the kidney. And you have your nephrons, these little, I don't know what they look like. They look like fish fins to me, like little fishy fins. So blood enters via the renal artery for processing, and then filtered blood exits the renal vein. And waste products obviously exit through the urinary system. Kidneys go down through the ureters. The ureters lead to the bladder. The bladder then leads to the urethra. And then the urethra then leads to the outside world through the meatus, which is the opening of the urethra. Okay. The bladder is a very muscular, it's a muscular muscle, duh, Jessica. It works with those stretch receptors that we talked about last week. So when there's a lot of urine in there, it says, hey, I'm full, and you get the urge to urinate, okay? Men have a prostate gland that wraps around the urethra. So it's literally like the urethra goes through it. So when you have swelling of the prostate and it swells in like towards like into itself, that's when you have constriction from the prostate. So BPH, prostatic benign hyperplasia. Okay. Women do not have prostates. Please remember that. There's a reason I have to say it. So this is the very, very complicated anatomy of the nephron and how it works all. Yeah.
On her laptop, she just put it in the chat.
Yeah, I think I did.
Okay, thank you.
She did. Thank you.
So the kidney contains over 1 million nephrons. The cortical nephrons sit high in the cortex, while the juxtamedullary nephrons are deep in the medulla to concentrate the urine. I don't need you to know that. It's just A and P. Okay. I want you to know what a nephron is, but I don't need you to know that there's different types of nephrons. Okay. So we have the glomerulus, which is contained in the Bowman's capsule. This stuff is important. The glomerulus is inside the Bowman's capsule, okay? And it's kind of like a strainer, it strains things. So then you have your proximal convoluted tubule, okay? This is like a conveyor belt where it sorts things into different places. It sorts potassium, it sorts your sodium, it sorts your calcium, it sorts all the things, okay? Down this, we have the loop of Henle. This is where concentration occurs. Okay, this is where Lasix or furosemide or bumetidine work because they are loop diuretics. They work in the loop of Henle. Okay. Oh, it's missing something. When it comes up, this is the ascending loop, but it's missing that. So we need to know that part. Yeah, because it does something important. So the descending loop concentrates by pulling water out, so making whatever's in here more concentrated, right? That's the loop of Henle. Yes, the loop of Henle. And then the ascending loop is where we have sodium and chloride, either release or retention.
Can you repeat the
The loop, the descending loop?
Yeah.
Yeah, this is where water goes out and it becomes more concentrated. Which is why loop diuretics work the best at diuresis, because that's where all the water, the majority of the water is released and everything is more concentrated. So that's why loop diuretics work better than all the other diuretics. Okay. So
So the ascending loop does sodium and what?
chloride.
Thank you.
So the ascending loop actively reabsorbs ions, which is sodium, potassium, and chloride in the ascending loop. So this is where water goes out and everything gets really super concentrated. And then it comes up here where we have reabsorption of sodium, chloride, and potassium. Okay? So then we have the distal convoluted tubule, which is all about fine tuning. And this is where really fine regulation of the extracellular fluid and electrolyte occurs. What happens there again? Just fine tuning of the electrolytes and extracellular fluid. So it's like almost like the last step of balance. So the collecting duct, this is controlled by ADH, which we're gonna read or learn about in a little bit. When we talk about endocrine, ADH is antidiuretic hormone. And this is the last step of water, electrolyte, and pH balance happens with homeostasis. So it all starts here at the beginning of filtration, does all this work just to be able to be perfect at the end to achieve homeostasis. Where's the nephron is inside here. There's millions of them. Oh, inside the little fish fins. Okay. And imagine there's millions of these constantly working at every second of every day. Okay. So you have a 3-step production where you have glomerular filtration. The glomerulus acts as a non-selective filter, dumping fluid and solutes into the tubule. It's actively collecting, it's like the garbage collector, right? I want to collect all the stuff and all the blood, okay? Then we get to step 2, which is recovery, the tubular reabsorption. This is where water and essential nutrients from the filtrate come back into the bloodstream. And then we have secretion. Active transport pulls drugs and toxins from the blood to be excreted. Okay. So throughout this whole process, at the end, we have our byproduct of urine that our body needs to get rid of. Full of sugar and glucose and ions. And go ahead. So this is like, it's a very compact version of the last slide. Okay, thank you. Mm-hmm. More of a basic understanding of the previous slide. So we have to regulate the fluid, okay? All these people are on this kick of drinking a gallon of water a day. By the way, it's ridiculous. We can't, that's a lot of water, guys. That's like a lot of water, okay? And you're just dumping the water in just for it to come right back out. I don't understand. But anyways, if you do that, good for you, because I can't drink that much water. So the goal is to maintain volume and composition of body fluids. And we do this with dilution versus concentration. And the renal tubules, the whole nephron, is what determines your dilution versus concentration for homeostasis. The volume of body fluid is strictly controlled by either diluting the urine, which is excreting more water, or concentrating the urine by retaining more water. And this is just part of the job, right? We're not even, yes, it talks about electrolyte balance, but right now we're only really talking about volume. Concentration versus dilution. Okay. So sodium is the big guy in charge. Sodium is one of the most important electrolytes that we have. And it gets very testy when it's out of range. So we talked about last week how water follows salt. And that is a way of water crossing a barrier. Because if you have a lot of salt water in one cup and a lot of water in another cup, and you create a bridge, you will have water that does not have a lot of salt flow into the cup that has a ton of salt, because water is always going to be attracted to those ions. Okay? So 65% of filtered sodium is reabsorbed immediately in the proximal tubule, and this happens by passive diffusion, where water is following the salt. Okay. What is the normal sodium?
135 to 145.
Good. So looking closer at the loop of Henle, again, we talked about the descending, this is where the descending loop is, where a lot of is where your concentration occurs. So water leaves and the filtrate becomes very salty. It has a lot of solutes. So when you get over to the other side, it's the ascending loop. So permeable, we talked about if something is permeable, it's very easy to pass through, right? So it's very water permeable. On the other side, it's water impermeable. Okay, so water is not allowed here. It doesn't come in and out of here, but salt is allowed to come in and out of here. So this is where your regulation of sodium, chloride, and potassium happens a lot. For potassium, potassium is is our second most important. I honestly feel like sodium and potassium are like both number one, to be honest with you. They're both so problematic when they're not within normal range. Okay. So potassium is vital for nerve and muscle function. 65% is reclaimed early in the process. So what part of the filtration is early on? So you have the glomeruli, and then what does it go down into? The loop of Henle, right? And when we take furosemide, what are we most at risk for when we're talking about electrolyte disturbance? Low potassium. So it's saying 65% in the process. So if we're not recollecting potassium in that early process, that's why we're losing so much, because the also thing that happens in the early process is the loop of Henle. So if your diuretic is working over there within the loop of Henle, that's why your potassium is getting so excreted so fast and you're becoming hypokalemic. That makes sense. I feel like I said that really weird. Huh?
Because it's all coming out.
Because it's coming out, yeah. Because because you want diuresis. So if you're making diuresis occur within the loop of Henle, and 65% of it is being reabsorbed in the very beginning of the process, where the loop of Henle is, you're going to be losing a lot of that you were supposed to be retaining.
Because the medicine takes out
because the medicine is working in the place where potassium is not supposed to be excreted. It's supposed to be concentrated. So fine tuning in the distal convoluted duct, the body retains sodium and excretes potassium if the potassium levels are high. So potassium excretion happens all the way at the end in the distal convoluted tubule. Okay, it's not supposed to happen in the loop of Henle. It's supposed to happen all the way over here in the distal convoluted duct. Okay.
So, okay,
Go ahead.
I'm a bit. So if it's supposed to happen in the distal Probably two.
Mm-hmm.
Why would happen in the Yes.
Why?
Yeah.
Because when you take a loop diuretic, you're forcing diuresis in that place. So when you're like forcing diuresis, you're forcing what those contents that are in all that water out. That mechanism of filtration and like holding on to potassium is like it can't really work
Because it's
regularly because it's being forced so forcefully out of that space.
So it can't hold on to it like it normally. Right?
Because the normal job is for it to concentrate.
Right.
I'm concentrating my ions. I'm concentrating my sodium, my potassium, my chloride, my calcium. I'm concentrating all of these things in the loop and Penley because that's my job. But if I'm not, and I'm just diuresing all of this fluid, my ions are going out with it. I can't keep it. I can't work more. I can't work the way I'm supposed to work.
Okay. That makes
How do they keep potassium high enough? Yes. Yeah. So if your patient is chronically hypokalemic, and so here's the thing. I have CHF, right? I've gained 17 pounds of fluid and I can't breathe.
Right.
Is diuresing going to be more important or keeping my potassium stable without supplementation more important?
Okay, but I guess what I'm saying is if they replace it with supplements, is it just gonna keep flowing out or?
It would have to be a fine balance, and that is where nephrology gets so complicated.
Okay.
Nephrologists are actually some of the most intelligent physicians I've ever met. Nephrologists and endocrinologists, because it is true chemistry. And it's all about this like predictability and these formulas to figure out how your patient is going to react versus the kidney function that they have, and trial and error.
So most people who take with diuretics are problems.
Mm-hmm. A lot of people that take diuretics, except potassium sparing diuretics. Well, we're going to talk about that, you silly goose. We're only talking about this. We're not out
Is
there
that why
yet.
they put like potassium and like certain blood pressure pills like
Carissa, say that
Losartan?
again.
So is that why they put like potassium in certain blood pressure meds, like the ones that you tend to go hypokalemic with? They'll add potassium to the pill. So like Losartan has potassium in it, and like certain ones have like salt in them, so that it helps balance it out.
Maybe, but what is, and you just brought me into a good question, and I'm pretty sure it was on your exam, which hypertensive medication puts you at risk for hyperkalemia?
I think I got that wrong on the exam.
Lisinopril.
It was no.
Your ACE inhibitors are going to increase your risk for hyperkalemia. Okay, so calcium regulation and vitamin D. Vitamin D from the diet must be activated in the kidneys to allow the gut to absorb the calcium. You have to have both to be able to absorb vitamin D. Okay. We are going to get into this in a couple chapters. Levels are maintained by the parathyroid, PTH, and calcitonin. We're going to talk about that in chapters 34 through 38.
What do you have to make sure you?
In order for vitamin D, no, I'm sorry. In order for calcium absorption, you have to have vitamin D.
Okay.
And vitamin D gets activated in the kidneys.
Okay.
Calcium, so circle this right here. Calcium absorption requires vitamin D.
Thank you.
Mhm. So we eat vitamin D and it's inactive. It has to go to the kidneys to become activated to be able to use calcium in the bones.
Oh,
Okay.
okay.
Aldosterone, the salt saver. First of all, that kidney looks dead. That is not a good looking kidney. Kidneys should be nice and pink. Okay. But again, it shows the adrenal gland and the adrenal cortex on top of the kidney. Aldosterone release equals sodium being saved and potassium lost. Sodium and water retention. Aldosterone causes sodium and water retention and the loss of potassium.
Why is potassium lost if the sodium water is safe?
So it's because it stimulates the sodium potassium pump. And if I'm
Okay.
holding on to
So,
sodium,
yeah, you're getting rid of
I'm naturally excreting potassium. This is triggered, aldosterone is triggered to be released by, and remember, we're talking about our negative feedback loops, our negative feedback systems. So what causes my body to say, hey, I need aldosterone? Hyperkalemia, sympathetic stimulation, like your sympathetic nervous system, and angiotensin 3, because that's where aldosterone is secreted in the RAS system. How do we feel about that? Angiotensin 3 in the RAS system is what goes to the adrenal cortex.
It causes it to
Release aldosterone,
which then save water.
which then causes sodium and water retention and the loss of potassium. And in turn, when you have water and sodium retention, your blood pressure goes up. So, aldosterone is a hormone, and so is ADH. ADH is your antidiuretic hormone.
And they're not the same,
They are not the same.
but they do.
The opposite.
Wait, what's your
Aldosterone. So if aldosterone causes the retention of water and sodium,
Yep.
ADH is going to release water and sodium.
Is that why they?
So ADH is released from the hypothalamus. And the things that trigger the negative feedback system is a low blood volume, rising sodium, and sympathetic stimulation.
Can I ask a question? Why would a low blood volume?
I know, I was just thinking that. Hold on. Because now I have to use my brain.
Sorry.
No, it's okay.
Okay.
Aldosterone causes you to hold fluid.
Right.
Come on, Jess. Antidiuresis. I need to get my brain checked. Huh? What did you say?
No.
I'm talking to myself too. Maybe I should have had somebody teach for me.
You do.
Oh.
Does the low blood volume have anything to do with like not having enough like urine to get rid of?
Okay, this is what I need. Okay, so aldosterone promotes sodium reabsorption, which we know, causing water to follow passively, which is why we have sodium and water retention. ADH directly increases water permeability in the kidneys, which conserves water. So, when blood pressure or blood volume is low, the RAS system increases aldosterone, while low pressure also signals the posterior pituitary to release ADH. Together, they maximize water retention and increase blood pressure. So it's not opposite, they work together. Okay? So aldosterone is part of the RAS system, which increases aldosterone, causes water retention, sodium retention, right? ADH is released and maximizes water retention and increases blood pressure. So it's saying that with ADH, you have more concentrated urine because your water is being retained in the body. How are we feeling about that? Did I just confuse you or did
Confused.
so they're working together. They're not opposites. I know I could just confuse the shit out of you. Let's take a 10-minute break because we've already been here for an hour. Let's take a 10-minute break when I do this, and I will be right back. Okay?
Why are you looking at me like that? You just went out.
Once more, mind you, before they secured aid. Thor fastening the
Okay, I'm back. Okay, so all right, ready?
Yes.
All right, so we know that aldosterone is produced in the adrenal gland. Okay, it's released into the circulation and responds to high potassium, the sympathetic stimulation, or angiotensin 3, which we already talked about. It stimulates a sodium-potassium exchange in the cells of the distal tubule and causes reabsorption of sodium in exchange for potassium. So we know it holds on to sodium, it holds on to water, right? So aldosterone increases water retention, sodium retention, and exchanges potassium. So excretes potassium. Yes? All right. So ADH, antidiuretic hormone, is important in maintaining fluid balance. It's released in response to the falling blood volume, sympathetic stimulation, rising sodium levels. ADH release allows the body to finally regulate fluid volume.
So your kidneys.
Is that really all we're going to say here?
Your kidneys reabsorb it back to the bloodstream.
Yes.
Water. Yeah. So that way it makes more blood volume. And it's, where sodium is, water goes.
So I know, I feel like I just need to move on because my brain is circuiting.
come together like.
Yes, because we're gonna talk about
Hey,
endocrine in the next.
Miss Simmons, can you
Yes. What did I do? What? Yes.
let Steve?
I don't have anybody in my waiting room.
Oh, she said she
I don't know.
was.
Nope. Not yet. Not right now.
I'm texting her back right now.
Okay. So we talked about the negative feedback loops. Your RAS pathway is for when your kidneys aren't getting enough perfusion, which is because the pressure isn't high enough. So it increases the blood pressure. And then this is the erythropoietin. So it responds to the low oxygen of hypoxia. The kidneys release erythropoietin, the bone marrow stimulates red blood cell production, and then increases the red blood cell production. I want to.
She's in the waiting room now.
Okay. Oh yeah, I see her now. So when we're talking about the lower urinary tract past the kidneys, we talked about the ureters. The ureters move with peristalsis. Peristalsis, do you know what peristalsis is? It's the wave of movement. It happens a lot within the intestines. It happens in the esophagus. It's a one-way street. We don't want it to go the other way, right? Peristalsis makes sure that things move in the right direction. So peristalsis also occurs in the ureters. We talked about the bladder being a muscular storage pouch. And then the urethra is the exit pathway. We obviously have an increased risk of infection, especially in women, because women have a shorter urethra than men. And that's why women are more at risk. Okay. I always think of the bacteria as like little like marching guys, and they're like marching up the Foley into the urethra. And with women, they have a really short march, but with men, they have hopefully a longer march. And it takes them longer to get there. You're funny. So when there's something wrong with the kidneys, something is wrong with our 4 different types of things that are controlled by the kidneys. So we have fluid overload with fluid accumulation, anemia because of loss of erythropoietin, electrolyte imbalances, especially sodium and potassium, and then waste buildup, which when it gets really, really bad, then we need dialysis. So when we talk about diuretics, there's a couple things I want to say about ions really quick. So when we talk about, we talked about sodium. I want to talk about potassium. So potassium is vital to proper functioning of the nervous system. We talked about that. Cells and cell membranes, specifically the muscles of the heart, right? The cardiac muscles. This is the piece that was missing. 25 to 30% is reabsorbed in the ascending loop of Henle. So if your loop diuretics are working in the loop of Henle, that 25 to 30% that's supposed to be reabsorbed is not being reabsorbed. That was our missing piece. Does that make more sense? Okay. So if levels are very high, retention of sodium in exchange for potassium leads to the retention of water. Oh, yeah. So we have a missing piece here. 25 to 30% of potassium is reabsorbed in the ascending loop of Henle. So if the loop diuretics are working in the loop of Henle, where 25 to 30% of your potassium is reabsorbed, that's why it's not. That's why you're excreting all of that, because 25 to 30% of it is a huge chunk. Yeah, I mean that's exam 1, 25%. No, there's a chunk. Yeah. That makes more sense. We talked about calcium. We talked about how calcium from the GI tract is regulated by vitamin D that is ingested, and then it has to be activated by the kidneys so that calcium can be absorbed into the bones. Yes? Okay. All right. Now let's move to diuretics. Any questions about the RAS system? Obviously, we need to go over ADH. Your girl knows that. But I'm going to give my brain a little break for a second on that concept. But is there anything else that we talked about in chapter 50 that we need to touch on?
Yes, but no.
Yes, but
So it's
no.
okay.
If it has anything to do with ADH, we're gonna get back to it, I promise. But for some reason, my brain has a very large block against ADH right now, and I don't want to confuse you any farther. Okay? And we're going to talk about it with endocrine, which is my saving grace. Okay, so no, we're still in. I combined them.
Then we start on that. Working.
Thanks. So sodium excretion drives volume reduction. Okay, so where you have normal reabsorption and then diuresis changes your normal reabsorption of sodium. Okay. So diuretics are going to prevent the renal tubule from absorbing excessive sodium. And the result is that sodium and ions are lost in the urine rather than returned to the blood. So when you have an increased urine volume, you're also going to have an increased sodium excretion. Because where sodium goes, water follows. So if I'm dumping urine, I'm also going to be dumping my sodium with it. Does that make sense?
Sorry, you said it's increase your.
Yes, so increased urine volume also is increased sodium excretion.
So is that why you said it's not really good to drink the first day?
Well, no, because you're thinking about now when you are a healthy person, I don't care how old you are, if you are a very healthy person and you have healthy kidneys and you drink a gallon of water a day, your body is going to compensate for that. Your kidneys are going to compensate for that. But if you have any level of renal failure, that compensation, that mechanism is going to be decrease, right? So when we're talking about that fluid regulation and homeostasis, it all has to do with the renal function. So if you need diuresis, something's not working right. A normal, healthy, kidney functioning human should not need any diuresis. Okay? So diuresis is going to change the way that your sodium is reabsorbed. Okay? So indications for diuretics, we have edema management, which can be caused by heart failure. Acute pulmonary edema, which sometimes can be referred to as flash pulmonary edema, which is very scary if you see it in person. Liver disease like cirrhosis, and this can be alcoholic or non-alcoholic liver cirrhosis. Don't always assume because your patient has cirrhosis that they're alcoholics, because that's not fair or true. And renal disease, because your kidneys regulate your fluid. So if you have renal disease, your fluid volume is going to be messed up. So then we have hypertension, which is obviously the management of high blood pressure. Glaucoma, the decrease fluid pressure in the eye. There's a very specific type of diuretics that are just for your eyeballs. Okay. And electrolyte management, which sometimes can be a treatment for hyperkalemia. Not the main treatment though, by the way. So we have 1, 2, 3, 4, 5 classes of diuretics.
There's a lot of classes of everything.
There are a lot of classes of everything. There is. I'm not gonna lie to you. Pharmacology is so content heavy. But I like the idea of the flashcards. I actually just got into this education thing. It's called Level Up RN. I don't know if you guys have heard of it, but I got the flashcards for free, but I can't share them. I can only like like we could do it in class, but I can't like share them digitally with you, which pisses me off.
Can you print them all?
I don't know. I don't think I can print them. No.
Can you use Cam Scanner, like scan them in and share them as
Oh,
a
that would
PDF?
take a million years.
Hey,
But I would like to pull it up. Yeah.
if you have it on your Google Drive, because I bought the nursing school complete study guide.
Yeah.
I email it to whoever, like share it through my Google Drive, but I tell them not to download it from Google Drive, download it to their computer, and they'll have it permanently.
So there is no download button. That's the thing. With Level Up RN, there's no download button. You make an account, and the account has a membership that I got for free as an educator, but I can't download it. I have tried. I've tried so hard. But we'll look at it today. Okay, so the 5 classifications of diuretics, we have thiazide and thiazide-like, which acts on the distal convoluted tubule. So it happens closer to the end, right? Look at the little picture it gives you. It happens closer to the end. We have our loop diuretics, which act on the ascending limb of the loop of Henle. And we know these are our best acting. These are what is going to promote the most diuresis. We have your carbonic anhydrase inhibitors. These are not super common. Okay. We have our potassium sparing diuretics, which act in the collecting duct, because remember, this is our very last step. This is where the fine tuning of our electrolytes happen, which is why the potassium sparing occurs here. We wouldn't want it to occur in the other places, okay? And then we have osmotic diuretics. I want you to put a star next to osmotic diuretics. There is one, which I'm sure we're gonna get to. There is one osmotic diuretic. It is called mannitol, Mannitol. I believe it has 2 N's. Mannitol. And mannitol is used specifically for cerebral edema. So too much fluid in the brain. Not blood, not hemorrhage, fluid. Mannitol specifically is for cerebral edema. You would never give mannitol to a patient that has CHF. It is a contraindication to give mannitol to a patient that has pulmonary edema or CHF. Okay? And we're going to get to that, but I want you to know it. What is it? What is it? Did I put that on?
No, this is the one that I'm not from.
How does cerebral edema even happen?
So I don't want to spend a lot of time on it because we're going to talk about it in complex care. Okay. But cerebral edema happens from trauma.
Okay.
So like you have like a traumatic brain injury, cerebral brain.
And that decreases ICP, right? That's the whole point here. I think.
Yes.
I don't feel that my brain's not.
Oh, yeah.
Right.
Okay, so sites of action within the nephron. So we have our osmotic diuretics and our carbonic anhydrase inhibitors are all the way over here, okay? We have our loop diuretics that work in the loop. It should really be on this side. And we have our thiazides and our potassium sparing that occur here, okay? So when we talk about considerations across the lifetime, in kids, you would want to be very, very careful with diuresis. They have little teeny tiny bodies and they don't have a lot of volume like we do, okay? I'm going to mention the ototoxicity, but we're going to get to it. Lasix, furosemide. Have you ever given furosemide as an IV push? Anybody? Anybody?
I didn't
anywhere?
get those.
Okay. What is the rule?
3 to 5 minutes.
You have to push it
3 to
low,
5
slow.
minutes. Slow. Why?
Does it burn?
No.
You don't want to drop their blood pressure.
So overwhelmed the kidneys.
No.
Toxicity. The range in
If
the ear.
you push Lasix fast, you can cause your patient to go deaf.
Death?
Deaf. Odo means ear. Odotoxicity. You can cause them reversible or irreversible hearing loss with IV furosemide if you push it too fast. Very, very important. And this makes it seem like it's only in children. That's not true. It's for everyone, every human. Okay? That is your zebra for Lasix, furosemide. Okay? So, furosemide does have a max for kids. I'm not testing you on max doses for pediatrics. You can do that, worry about that in peds, okay? It's important to know that most pediatric doses are gonna be weight-based with any drug, okay? Adults, obviously you wanna monitor for fluid imbalance, instruct to weigh daily, and on the same scale, in the same clothes, usually naked, right, at the same time. And remember we said more than 2 pounds in 24 hours, or more than 5 pounds in 7 days, they need to notify their provider. Okay. And then for older adults, we want to make sure that their renal and hepatic function is capable of diuresis. Pretty much this start slow and go slow is going to be your motto when it comes to the elderly humans. Because of the normal decrease in renal function in the elderly, if they consume a lot of salt, their salt regulation, even if they don't have renal failure, right? The salt regulation is going to be affected, okay? So high salt diets are not going to be good. And then frequent electrolyte monitoring, this would be for everyone. This is not just your elderly. I mean, yes, it is a bigger risk for your elderly, and it's also a bigger risk for your kids, but it's a risk for everyone across the lifespan. All right, so thiazides and thiazide-like. The most common thiazide is your hydrochlorothiazide. This is a very common antihypertensive medication. Thiazide-like, they are not very common. Not common at all.
The thiazides aren't.
The thiazide-like, these ones, are not very common. They have identical indications and they work very, very similar. So it's basically saying they're basically the same, okay, the way that they work. Their chemical makeup is going to be different, but their mechanism of action is the same, okay?
So the thiazide like is like a knockoff brand.
I mean, I guess you could say that. Yeah. But no. But if that if it helps you say like they're pretty much the same, but
The thiazide is better.
it's the great value. Necessarily better because the mechanism of action is the same.
Okay.
You know?
So it's name brand and great value brand.
So why do people use thiazide like versus thiazide?
That's a doctor question, my friend. And your girl is not a doctor. Great question though. Okay, so thiazide's mechanism and indication. So it blocks the chloride pump in the distal tubule. It prevents reabsorption of chloride and sodium and excretes it in the urine. So if it blocks the reabsorption and it pushes sodium into the urine, what is it going to cause to follow it? Water, which is how it initiates water loss. Because if it's letting go of sodium, my water is going to follow my sodium. And if I'm excreting it out of my urine, then my water will follow. Okay? The primary indication is the first line management for essential hypertension. So is the chloride part really important? I mean, do we see chloride disturbances? Yeah, sometimes. Not majorly. It's the sodium that is the big guy. Okay? Because hypo and hypernatremia at first can cause confusion, neurological issues, and if it gets severe, can cause seizure activity, and then coma and death. So sodium imbalances are very serious, just like with potassium, imbalances can cause cardiac arrest.
So what does chloride do for the body?
Great question. Okay.
For a doctor.
Glad you. Okay, so pharmacokinetics and contraindications. It does cross the placenta and enters the breast milk. We absorb it. This is a PO medication. Okay, thiazides are not given IV. This is a PO medication. It is metabolized by the liver and excreted in the urine. Okay. Now, I want to say something across the board. Okay. An allergy to a drug is always going to be a contraindication. Okay? Because I don't want to say it a million times. Because it's going to say it a million times. And I just want you to know it. Now, if, say, you are dying of some crazy disease and there's only one drug that can save your life and you're allergic to it, guess what? You're getting a lot of Benadryl and we're going to save your life. A lot of steroids, a lot of Benadryl, and some epi. Yeah. Okay? But I'm talking about death, right? In regular old all day life, an allergy to a drug is going to be a contraindication. Okay? Fluid and electrolyte imbalance. If your patient is already hypovolemic, if we give them a diuretic, they will be more hypovolemic and then can go into hypovolemic shock. That is a bad thing. That is a contraindication. Severe renal disease. What is anuria? A-N-U-R-I-A. Anuria. It is basically no urine. But technically, how many mLs or less per day?
Is it 30?
50. The normal amount to urinate or make the normal amount of urine that you make in a healthy human every hour is 30 mLs per hour. Okay, that is the normal amount for a healthy human kidney. Anuria, and don't get tripped up on these because I've seen it in the past with my these last two courses that I taught. They get confused with the 30 versus 50. A-N-U-R-I-A. Anuria is less than 50 mLs per day, all 24 hours. What is oliguria? O-L-I-G-U-R-I-A. Very close. It's less than 400 mLs per day. Oliguria is characterized by less than 400 mLs per day. So would you want to give thiazides to a patient that has anuria?
No.
No, no, no. No. So there's a difference between being cautious and contraindications. Okay. So we want to be cautious in patients that have lupus, SLE, systemic lupus erythematosus, something like that. Erythematosus, something like that. SLE is lupus. Diabetes, Doesn't matter, type 1 or 2. Hyperparathyroidism, which we'll talk about in endocrine. Bipolar disorder. Why bipolar disorder? Have we learned about psych meds yet?
Can it
So,
interfere with like medications like lithium?
Yes, who said that?
I did. Stevie.
Stevie. I only caught the end. What did you say at the beginning? Repeat it.
It can be a contraindication with meds like lithium since it's a salt-based medication.
Yes, but why?
Well, it can, because you're excreting urine and taking the salt, you can be at risk for lithium toxicity.
Mm-hmm. Now, what about digoxin?
With digoxin?
Uh-huh.
With what, thiazides or lithium?
Thiazides. I'm only asking because you're relating it to salt. You're on the right track. You're on the right track. Okay, so
I don't know about digoxin because I feel like with digoxin, I don't know about the salt. I don't know if thiazide would have anything to do with potassium because I know with digoxin, if you have the hypokalemia, then you're at risk for the digoxin toxicity.
okay, so we're talking about therapeutic ranges, right? Our digoxin window is very small, 0.5 to 2. Our lithium reference range is very small. I don't remember the exact numbers, but it's very small. Narrow is what we call it. Okay. So when you have drugs that have a very small therapeutic window, any diuretic is going to cause a possible toxicity. Okay. So if your thiazides are pushing all your salt out, and she's saying, because Stevie, you were a pharmacy tech, right?
I'm a medical assistant.
Medical assistant. How do you know these things?
I
thought
used to
you had
take
something to do with
lithium.
a pharmacy. She said I used I didn't mean to call you out like that, okay?
No, you're good. I know things.
She's like, I didn't mean to call you out like that, girl.
And I also paid attention when you were talking about it.
I love that for you. Okay, so when we're dumping out all of our salt and our fluid or our water is following the salt, and she's saying that lithium is a salt-based derivative, then it's going to follow into the urine. Okay. If my digoxin has a small therapeutic window and I'm, where does it say it happens? It happens in the distal convoluted tubule where all of my fine tuning occurs, right? And if I have disturbances in my potassium, then it's going to mess with my digoxin level. Okay. So the adverse effects of thiazides would be dizziness and vertigo. This is because of fluid loss. Okay. When we have low fluid, you're like dehydrated and you're like, woo, I stood up way too fast. Okay. That's going to be basically with every diuretic. Okay. Hypotension, every diuretic. Hypokalemia, every diuretic except for the potassium sparing diuretics. Okay. And then hyperglycemia is for prolonged use. Saw something. For anyone interested in Level Up RN, you can go on their website, pay $10 a month for an online membership. You have access to flashcards, video. Yes, I know. I know, it really is so good. I want to show it to you again. It can cause GI upset, decreased calcium excretion in the kidneys, and then it could be an issue with gout. Gout is caused by the buildup of uric acid within the joint, specifically the great toe, by the way, which is the big toe, is the main source of a gout exacerbation. So if you're diuresing and you have a large accumulation of uric acid, it can cause an exacerbation of gout. Okay, so how does uric acid get all the way down? Great question. She has good questions, guys.
You're gonna have to Google this.
So-
Let us know what you find out.
Digoxin plus thiazide is going to be a high toxicity risk due to hypokalemia. Lithium, it just says lithium toxicity. It doesn't relate it to the salt, which was a really good point. I like where you went with the salt. Anti-diabetic agents, your glucose tolerance changes, so the dose may need to be adjusted. Okay, because it said prolonged use causes hyperglycemia. So you may need to increase your anti-diabetic agents. And then other antihypertensives can, if you add it on, can cause more hypotension. So this is just taking a closer look at hydrochlorothiazide. Adjunctive therapy for edema and can be used for hypertension, the first line of hypertension, or in combination. So monotherapy, meaning it can be used by itself for hypertension, and then combination, it can be used in combination with other drugs for hypertension. The only time I am really interested in you guys being, if I need you to know the peaks, the onsets, and the duration, I will tell you. You will need to know the peaks, onsets, and durations for insulin specifically, right? And we'll get there. So do I need you to know this? No. Adverse effects, dizziness, orthostatic hypotension because of the fluid loss, hypokalemia because of the potassium loss, polyuria, that just means you're peeing a lot, muscle cramps, why?
Because it's dehydration.
Potassium is involved with muscles. Calcium is involved with muscles. Sodium is involved with skeletal muscles.
So if we're getting rid of all of them.
So if we're getting rid of all of it, then we're gonna have issues with muscle cramps. And it gives you the answer. So thiazides block the chloride pump in the distal tubule. Sodium passively moves with chloride to maintain electrical neutrality. So that means if the sodium and the chloride aren't combined together, it's blocking the chloride, causing the sodium to dump. Okay? I would never use a question like this, but oh good. I don't like it. Loop diuretics, the powerhouses, the main guys, the best little worker bees. We have furosemide, which is Lasix, bumetidine, which is Bumex. And you can see furosemide sometimes. I've seen it a couple times. The last one I've never seen in my career. It blocks the chloride pump, decreases reabsorption of sodium and chloride. It's named for the loop of Henle and causes rapid and extensive diuresis.
For our tests, are you asking us these words or in the quote?
What are those words?
The off-brand name, right? The generic?
Generic. So generic versus brand. The NCLEX specifically uses generic.
This one.
The long one. The harder one.
NCLEX uses the big ones.
The NCLEX uses the bigger ones, yes.
Oh, okay. All right.
Unfortunately, yes. Okay. Do you give a loop diuretic to a patient that's anuric?
No.
No. Because you can't. Wait. Yeah. Because you want them to be?
You can. Yeah, you can. Oliguric, yes.
Which one's the one you don't give them?
Thiazide. Because furosemide is your biggest, heaviest hitter, you can see a small increase in urination with loop diuretics when you're oliguric or anuric.
Okay, so I'm sorry, I have a question.
Go ahead.
Why did we not use those?
They don't. It depends on where it's working within the nephron.
Okay.
And the loop of Henle is where most of your water is lost. which is why you can use it when you have a very low amount of urine out. The place that thiazides work is it doesn't diurese as heavily. And if you have renal function loss, then that electrolyte balance, that fine tuning where it works, that is compromised. And it doesn't diurese very well. So if you give a very like low level diuretic like a thiazide, it's just not going to work very well at all.
Is loop diuretics contraindicated in kidney failure?
Contraindicated, I would say more of a caution. And we have different stages of kidney failure. So
In the initial stages of kidney failure, I think loop diuretics are normally prescribed to try and help your kidneys. But when you're in later stage kidney failure, you don't produce a lot of urine. It doesn't really do much good.
if you have absolute zero function of kidneys, then yes, any diuretic is going to be contraindicated. You have no kidney function whatsoever, then there's no point. It's not going to do anything. You will have to have dialysis. Indications is rapid fluid removal, so acute heart failure, acute pulmonary edema, and then renal or liver edema. Adverse effects, we talked about the ototoxicity. That's very, very important. That's your zebra. Hypokalemia, because it's just going to cause you to lose more potassium. And dehydration, because it's just going to put you at a higher risk of hypovolemia. Again, you want to be cautious with lupus, gout, diabetes. So this is just saying that your other classes, like your carbonic anhydrase inhibitors and your thiazides, they're very mild related or like comparative to the loop diuretics. We're gonna skip. We're gonna bring something else up now. Do you guys have break suites pulled up? Or at least a piece of paper? Yeah. Okay. There's stuff over here that I do not want to not cover. So your carbonic anhydrase, this is going to be your acetazolamide. This is for glaucoma. This is to reduce the fluid within your eyeball. The acetazolamide. Is that the only thing? Or is it the only thing? Is it the only indication? The indications is adjunct. Okay, so I just want to make sure I'm not missing stuff. That's why I pulled this up. So I want you to get another piece of paper. And this, make sure you go back in your recording.
And you said this is just for
The eyeball.
This is for glaucoma.
All three?
All three of them, but acetazolamide is going to be your most common.
I don't know. It's noisy. I don't need you to know all three.
Okay.
Okay, take care.
So we are going to talk a lot when we get to in a complex care. We're going to talk about a lot of hydrogen ions and bicarbonate and how this works with acid-base balance. Okay, so you're going to see this come up again later on when we talk about acid-base balance. But the indication for our purposes right now is glaucoma. So this is contraindicated in non-congestive angle closed glaucoma. There's multiple different types of glaucoma. Okay. There's open angled, closed angled. So this is contraindicated in non-congestive angle closure glaucoma and pregnancy.
And that's talking about the drug acetazolamide.
You want to be cautious with fluid or electrolyte imbalances, obviously, for all diuretics. Renal or hepatic disease, because it's excreted in the kidneys. Yeah.
Was this 51?
This is chapter 51.
Okay, I just want to make sure.
It's excreted in the kidneys and metabolized in the liver. Adrenocortical insufficiency, because it messes with your steroid production, which we will talk about in endocrine. Respiratory acidosis. Because of the loss of hydrogen ions. Well, the loss of bicarb. And COPD, which COPD and respiratory acidosis is basically the same thing. These slides are also on Brightspace. Okay. So adverse effects, we talked a lot about acid-base balance. So our pH of the blood. Because of the loss of bicarb, bicarbonate is our base. Okay, so when you have something acidic, we have to neutralize it with a base, right? So our base in our bodies, in our human body, is called sodium bicarbonate. Okay, so if it's causing the loss of sodium bicarbonate, then it's going to put me at risk for acidosis because there's nothing neutralizing my acid. Does that make sense? Without diving too deep into acid-base balance. So sodium bicarbonate equals base. Hydrogen equals acid. I just want you to, be able to wrap your mind around why the loss of bicarb is causing acidosis. What is paresthesia? Tingling. Tingling and numbness in your fingers, your arms, your legs. What are salicylates? Aspirin. So am I gonna take this with aspirin? It's putting me at risk for hypokalemia. So am I going to take this with other drugs that cause hypokalemia?
Yeah.
These are eye drops. For our purpose, we're talking about eye drops. So acetazolamide is used for open angle glaucoma. It can be used for acute angle closure glaucoma, which is not the one that it was contraindicated for. That was like non-congestive. Okay. So it decreases the aqueous humor, which is the fluid in the eyeball. Aqueous humor, that's our eyeball fluid. Intraocular pressure, so the pressure within the eyeball. And hydrogen secretion by the renal tubules. So I just told you that hydrogen equals acid. So if it stops, it inhibits the secretion of hydrogen, then that means it's increasing your acid, causing acidosis. Okay. And it also said that it secretes your bicarb, which is going to even worsen the acidosis. Okay. Potassium sparing diuretics. So these are good, but they're not as good as your loops. They retain your sodium instead of wasting it. Spironolactone is going to be your most common potassium sparing. She said, I need a break. Okay, let's take a break. I mean, it is 1:38. What time are we here till? 2:30? It's an appropriate time for a break. Let's take 10 minutes and come back. All right. Let's get this day over with. So we were talking about potassium sparing, where we said that our spironolactone, which is aldactone, is our most common potassium sparing medication. So it causes the loss of sodium, but retains the potassium. So the indication is for people that are at really high risk for hypokalemia, and they don't need like powerful loop diuretics. Adjunctive treatment for edema. It has shown improvement for survival rates for patients with heart failure. And then we're going to talk about hyperaldosteronism when we get into our chapters 34 to 38. But it is an indication for hyperaldosteronism, which is when we secrete too much aldosterone. So it's contraindicated for patients that have hyperkalemia, obviously, severe renal disease, and anuria, so severe end-stage kidney disease. Now, it says that it crosses the placenta and enters the human milk, but it doesn't say that pregnancy is a contraindication, which leads me to believe that it is only used if it's absolutely necessary to use it. So it's not a contraindication. It's not going to give your baby 3 eyeballs. It's not teratogenic, means it's going to fetus deletus. It's a word. Good word. You'll never forget that one. So it's going to be used very carefully. So it says it's used with caution in pregnancy. It will not delete your fetus. Adverse effects, of course, is hyperkalemia because it's potassium sparing. If you see a young person, especially women, that are prescribed spironolactone, it is not for diuresis, it's for acne, because it can help regulate hormonal acne. It is an off-label use.
Is that what they call that, bacterial acne or something like that?
Nope, hormonal.
Okay.
Acne that's caused by hormones, and then acne that's caused by bacteria bacterial would have to be dealt with antibiotics.
Okay.
You want to be careful with other antihypertensives. Even though it's not used as an antihypertensive, it's still going to cause fluid loss, which can lead to hypotension. And antihypertensives lower your blood pressure. So if you add them all together, you could become very hypotensive. Okay. And then other medications that block renin-angiotensin-aldosterone pathway, which is going to be what medications? What medications that we just learned about work on the RAS system?
ARBs.
ARBs. ARBs and ACEs. So this is just taking a closer look at spironolactone. Your adverse effects are mostly going to be caused by the loss of fluid. So dizziness, headache, drowsiness, cramping. We talked about the hormone fluctuation. What is gynecomastia? Breast tissue. It is abnormal breast tissue in males. Gynecomastia, abnormal breast tissue in males. And also irregular menses, so it can throw off your period because it messes with your hormones, right? Deepening of the voice, So I'm pretty sure I would want to know if I was going to take a drug that was going to do that to me. Hirsutism. What is hirsutism? Hair. Hair in places it shouldn't be. Bearded ladies. Okay. But hirsutism is really just hair in places that it shouldn't be for women.
So basically, potassium sparing diuretics like give you like all the symptoms of being like a man.
Of being a man?
Of being a man.
No, it just messes with your hormone production because it can also lead to breast tissue in men.
Oh,
So men and women are going to experience the hormonal changes.
okay.
So, true or false, the loop diuretics cause the body to excrete a copious amount of potassium-rich fluid.
Well,
True.
wait.
True. I don't like the word copious. Oh, false.
False.
Oh,
It said copious.
okay. Loop diuretics block the chloride pump in the ascending loop of Henle, where 30% of all filtered sodium is normally reabsorbed. This action decreases the reabsorption of sodium and chloride. The loop diuretics have a similar effect in the descending loop of Henle, resulting in the production of copious amount of sodium-rich urine. So it's saying that loop diuretics cause you to lose sodium and water, right? We talked about the potassium loss, but the potassium loss is a smaller amount. The excretion is smaller. So I think it's saying that because you have such a large amount of urine, water follows salt. So if you're losing a lot of sodium and a lot of salt, it's going to be sodium rich. I don't like that question. I don't like that question at all. And I don't even like the rationale because it doesn't even explain why it doesn't have anything to do with potassium. So I would never use a question like that. And I don't like it. Okay, so this is our osmotic diuretic mannitol that I told you to write down. There's only one, and it's mannitol. It does not promote sodium loss. So the things that I want you to know about this is that it is the diuretic of choice for increased intracranial pressure, which we call ICP. It is the drug of choice for increased intracranial pressure, which we call ICP. I also really need you to know what the contraindications are. Specifically, pulmonary congestion, intracranial bleeding, dehydration, and heart failure. If I give my patient mannitol and I go back to assess them and I hear crackles in the lungs, what am I going to do? I'm going to call somebody. I'm going to stop the drug and I'm going to call a provider because this is a contraindication. If my patient starts showing signs of pulmonary congestion, I need to make sure I tell someone. I need to notify my provider.
Is mannitol IV or is it?
Mannitol is given IV. Why intracranial bleeding? What did I say earlier when we were talking about mannitol? It doesn't work on what? Blood, hemorrhage. It only works on fluid. Intracranial pressure caused by an increase in fluid. in the brain. So if you have cerebral edema from a hemorrhage, mannitol isn't going to do anything for you. It's only here for cerebral edema caused by fluid.
So it's not gonna make anything worse for the intracranial bleeding, it's just not gonna work.
Well, it's not going to work and it's a contraindication.
Because it doesn't work or because what?
Well, so if you have intracranial bleeding, what is that going to lead to? Fluid loss, hypovolemia.
Okay, all right, so more.
And if I'm causing more fluid loss, I'm already at risk for hemorrhagic shock. And then you're going to put me even more at risk for hypovolemic shock because you're taking all my fluid away. Okay? You want to use caution in pregnancy. Because it doesn't cause sodium loss. Remember on the first slide, it said without sodium loss. Whenever you have fluid and electron going back and forth, we call that a fluid shift. So without the sodium loss, you can have fluid shifts that can cause or exacerbate the patient's heart failure and pulmonary edema, which is why it is a contraindication.
What something super interesting though on mannitol,
Mm-hmm.
it says that it's contraindicated for people with renal failure, but years and years ago they actually used it in dialysis to prevent dialysis, like a disequilibrium syndrome.
Oh, because of
It's
the
no longer
fluid
used
shift.
for
Because
a long time.
Well, yes, I agree. Well, and it's not used for that purpose anymore. But disequilibrium syndrome is caused by massive fluid shifts. So I could see why they would think that mannitol could help with the massive fluid shift. That's interesting. So this is just taking a closer look at mannitol. Your adverse effects are going to include being hypovolemic, like dizziness, headache, hypotension, dry mouth, thirst, diuresis, fluid and electrolyte imbalances. These are all caused by fluid loss. Okay. So our carbonic anhydrase inhibitors, which drug was that? For the eyeballs?
Oh,
Acetazolamide. So
Glycine.
how does acetazolamide work? Does it slow down the reabsorption of sodium? Does it speed up the creation of sodium bicarbonate? Because remember, our patient are they alkalotic or acidotic? They're at risk for acidosis. Does it balance acidic and alkaline solutes? See? The answer is E. So the diuretics that block the effects of the carbonic anhydrase slow down the movement of hydrogen ions. Remember, I told you hydrogen ions equal acid. As a result, more sodium and bicarb are lost in the urine. Bicarb is our base. So we're causing acidosis. Okay. All right. At the end, that. This was the worst day to try to give you new material. Because my brain just can't handle it. You know what I mean? So this is our last chapter that we're gonna do today. UTIs are the second most common infection in the US. We already talked about shorter urethras in females are gonna be more vulnerable to repeat infections. Children may also have frequent urinary tract problems. What could excessive UTIs in children make people suspect? Sexual abuse, physical abuse, sexual abuse, neglect.
Are we not doing this one on space?
I just feel like I'm gonna forget things on that one. And this is gonna cover all my bases and I'm not gonna forget stuff. So I apologize. I should not have given you new material on this, on a day like this where my brain just isn't braining. But you can take notes on those, right?
You know what?
You sure can, because it's still paper and it still has the same, it has the same information, but I just don't want to forget it. Okay. So, patients with indwelling catheters or intermittent catheterizations often develop bladder infections or cystitis because whenever you put something in something that's not supposed to be there, you're introducing the outside world, you're introducing bacteria. Okay. So I'm assuming that almost everyone, if not everyone, maybe excluding the guys in our group, have experienced a UTI. Because like we said, never? You lucky duck. Never in your life. Wow.
I never have, but my daughter does.
That's amazing.
I never.
That's amazing. I mean, I haven't had one in a long time, but when I was little, and I used to get them from bubble baths.
Oh, really?
Yeah. But that was when I was like really little.
Yeah.
So signs and symptoms of a UTI is going to be urinary frequency, which is what we call polyuria. Urgency. Burning on urination. Okay. Chills, fever, flank pain. Your flank is right here on your back. That's your flank. And this is associated with acute pyelonephritis. So let's break our word down a little bit. Okay. So itis, inflammation, nephro, nephrons, pyelo, which is your kidney. So this is an inflammation of the kidneys and nephrons. And infection. So itis, inflammation, infection of the kidney and nephron. Okay. Some people may suffer from nocturia, which is nighttime urination.
Is that bedwetting or is that
No.
getting up and going?
Either or. Bedwetting and getting up to go to the bathroom are two different. Yeah. Then you're gonna have a wet bed, right? So nocturia is just urination at night.
Okay.
No matter, it's just urination at night. Whether it's in a toilet, a bucket, or a bed. Go ahead.
So, I have a question. She outgrew it now, but they put her on lactulose.
Ooh.
She was going to urinologist because she was having women, and like all during the day she'd be fine, but sometimes at night she'd go and it became like a problem, and they put her on lactulose, and once she got on the lactulose, her bedwetting stopped.
That's very interesting because lactulose is not only a laxative, but it also binds with ammonia. So those are its two indications. So I wonder what lactulose has to do with.
I don't know, but they was.
I wonder if it decreases like bladder spasms.
It was something about her bowels and everything.
Oh, so she's constipated.
She was constipated.
Yeah.
So they said.
Yeah. So I wonder if the constipation was putting pressure on the bladder, causing her to have bedwetting. Because lactulose can be used for, you can go to the bathroom daily and still be constipated. You can't, it's possible. Yes, very possible. Because what if you just have little rabbit poops every day? I mean, yeah, I poop every day, but it's not enough, right? So, older adults, sometimes the only presentation, and if you've worked in healthcare, you know these people be crazy. They can flip like a light switch, and it happens so fast. All of a sudden, I don't even know, Margaret is all pleasant, and the next thing you know, 3 hours later, she's telling you to go F yourself and throwing stuff at you out the door. You're different. Because girlfriend has a UTI. Okay? So, older adults can only present with confusion, disorientation, and other CNS effects. With our elderly, it can be your very first sign is confusion. Okay?
Hey, Ms. Simmons, I have a question.
Yeah.
So I'm a dialysis technician. People.
Yeah.
We had a patient that came in and the beginning part of treatment, she was okay, just like slight tremors in her hands. By the end of treatment, her whole body was, vibrating with tremors. They said it was a UTI. They fixed it at the rehab place. She came back and the same thing happened again. Could those tremors, I don't know if those tremors were a part of it because the UTI spread somewhere else, but is it possible for it to spread like that?
I mean, to me, that doesn't sound like a UTI. That sounds like an electrolyte imbalance. Because you can see that with a sodium imbalance and calcium, which is super common with dialysis. So anti-infectives, and we're going to talk about this next week when we go over antibiotics. So we're not going to hit antibiotics super hard right now because we're going to do that next week. But when you have a UTI, obviously, if it's bacterial, which it's mostly bacterial, you need to treat it with an antibiotic. Okay. And then other drugs, we can block the spasms of the urinary tract muscles. We can decrease urinary tract pain, like azo, like over-the-counter azo. Anybody ever taken azo? Were you a little scared the first time you peed?
I mean, it just definitely like tells it if you sneeze and you pee a little bit, it definitely like tracks it. Humbles you.
I did not read the box. I was not a nurse the first time I took azo, and I did not read the box. No, I did not.
Doesn't it change your urine color to like what, orange or something like that?
Radioactive.
There are multiple medications that change. Pyridium, yeah. So azo, which by the way is pyridium, yeah, causes your urine to become reddish orange and can stain your contact lenses, can stain your tears. But specifically, most importantly, we want to tell our patients that your urine is going to be orange, and when you pee, you're not dying. Okay? This is not you dying, Jessica. Protect the cells of the bladder from irritation. A lot of people believe that cranberry does this. Okay? And then treat enlargement of the prostate gland, and men will go over that. So this is just looking at the bladder and the sites of action where the drug actually works. So your urinary analgesics, the ones that relieve pain, are going to work within the bladder and the urethra, okay? Your antispasmodics are going to work within the muscle to reduce the muscle spasm. Your bladder protectants are going to work within the layer, the endothelial layer of your muscle, so the inner layer of that bladder. We're going to talk about BPH and how those work in the urethra, and we're going to talk about the testosterone blockers too. So, like I said, we're not going to spend a lot of time on antibiotics, but antibiotics specifically used to treat UTIs are fosfomycin. These are not, nitrofurantoin, that's a little bit more common. Which one's your macrobid?
Nitro.
The nitro? That's what I thought. So, before we had a lot of antibiotic resistance, most physicians were giving you like 3 days of macrobid. And then when we got more antibiotic resistant, you took your meds and then you stopped your meds. And then within a couple days, you had a raging UTI because it wasn't enough coverage. So giving someone macrobid for that 3-day period is no longer going to do anything. We need like a whole 7 days, 10 days, depending on the bacteria and depending on the antibiotic.
Patients take prophylactic.
Oh, I hate that. She said one of her patients takes it prophylactically. I hate that because that's how we get antibiotic resistant bacteria. I hate prophylactic antibiotics.
So do we need to know all of these?
No.
Okay.
No. Antibiotics used for UTIs and other infections. We're going to go over these next week. Ciprofloxacin, Cipro, and levofloxacin. These specifically have a very high risk and zebra black box warning for tendon rupture.
We need to know these, Mister.
I want you to know that. Tendon rupture with your floxacins. Cipro and Levaquin. Ciprofloxacin and levofloxacin have a black box warning for tendon rupture. So if I'm like, oh man, I got this UTI and I've been taking Cipro for 3 days, leg hurts. You better stop that shit and you better call your doctor. Which test? The test we just took? I was going to say, ATI, yes, that's a huge NCLEX question.
For tendon rupture.
Tendon rupture, yes, tendons. The most important things about antibiotics is you need to complete your antibiotics.
Yeah, always.
You need to teach patient education for compliance. Okay. Therapeutic actions, some act specifically within the urinary tract to destroy bacteria. We're going to talk about how antibiotics work next week with gram positive, gram negative, blah, blah, blah. We're going to talk about that next week. Okay. You want to be super, depending on the antibiotic, and I'm not testing you on this until next week, or, the final. Depending on the antibiotic is going to let you know whether it is okay for the kidneys, okay for the liver, okay for pregnancy and lactation. I mean, most of us have had a child. We know we can't take anything when we're pregnant, right? There's a very small list of things that we're allowed to take. Okay. So when it comes to antibiotics, your biggest, most common adverse effects, nausea, vomiting, diarrhea, all day, every day. Nausea, vomiting, diarrhea. Okay. Those are going to be your most common. By the way, this word dysuria, what does that mean?
Pain.
Also burning. Painful, burning urination. When you see the word dysuria, painful, burning urination. Okay. Antispasmodics, these are the drugs that are going to stop the muscle spasms. Okay. The most common is oxybutynin. That is your very number one most common medication on this list. Oxybutynin. So this blocks the parasympathetic activity which suppresses the muscle overactivity. So it leads to the relaxation of the urinary tract muscles. And it's used for bladder spasms, treatment of an overactive bladder, and other indications. So what causes a bladder spasm? You could have a patient that's post-op from a TURP. Do we know what a TURP is? Transurethral resection of the prostate. Yeah, good job. Yeah. So prostate, anything that something is sticking inside of your urethra into your bladder can cause a bladder spasm. Okay. Bladder surgery. Okay. Anybody have a continuous bladder irrigation? Not that you had it personally, but you've had a patient that's had a CBI? You've had it or you had a patient?
I've had a patient.
Yeah. So continuous bladder irrigation is usually following a TURP procedure where they have to continuously irrigate so you don't get a big, huge blood clot in the bladder after the TURP that blocks off the urethra and then you can't pee and then your bladder explodes. Not good. So when your bladder is holding that much fluid, the muscle spasms and it's painful. So this is going to decrease that spasm. Contraindications are going to include a pyloric or duodenal obstruction. Why? What kind of muscle is the pylorus? Where is the pylorus?
Is it at the bottom of your esophagus?
Other end.
Oh.
It is between the stomach and the small intestine, your pyloric sphincter. Okay, so we have sphincter muscles. Sphincter muscles are muscles that can dilate and contract. So we have our iris is a sphincter muscle, our pylorus, our urethra has a sphincter muscle, our rectum is a sphincter muscle. And you have another one at the end of your esophageal sphincter is between the esophagus and the stomach. Okay, so if you have, this is going to help with bladder spasms and it's going to, it can cause more obstruction of the sphincter muscle. So it can cause dysfunction of that sphincter muscle because it's relaxing the muscle. Okay.
All sphincters.
So it's going to work on all sphincters. Okay. You don't want to use it for glaucoma because what did I just say was in the eyeball? A sphincter. Okay. So caution. You want to be careful with renal or hepatic dysfunction because whenever you see that, you know if it's hepatic, you know it's being metabolized through the liver. If it says renal, you know it's being excreted in the urine. Okay. So this is taking a closer look at oxybutynin. Do you guys remember talking about anticholinergics and anticholinergic effects? Okay. So oxybutynin, its classification is an anticholinergic. So it dries you out. Yes. So you have drowsiness, dizziness, blurred vision because of dry eyes, dry mouth, nausea, decreased sweating. So it's affecting your, I can't even think. My brain is done.
Mm-hmm.
The sympathetic nervous system. So annoyed with myself. Quickly, the UTI or urinary tract analgesics, so pain relievers. This can lead to urinary retention and increase your risk of infection. If you are taking a drug like this, you should be on an antibiotic, okay? Because if you are in that much pain in your urinary tract, you need to go see a physician to see what's wrong. Why am I having painful burning urination? Why am I having urinary frequency? Why am I having to take azo over the counter if without a reason? You should not be taking this just all willy-nilly, okay? Go see a physician. So, azo is phenazopyridine, and it is a dye used to relieve urinary tract pain. It relieves the symptoms from urinary tract irritation from infection, trauma, or surgery. It works very well. It's a very good drug for when you need it. And it works very, very fast. You want to be careful with severe renal or liver dysfunction, and you want to use it cautiously in pregnancy and lactation. You want to make sure you're giving your patient education about the reddish orange coloring of the urine and staining of the contact lenses. Have you ever heard of scleral contacts? So scleral contacts are called hard contact lenses, and they actually take.
You put in with the liquid, and it's like a stand, and they have liquid in them, and you put them in like that.
Yes, but it doesn't just cover the iris and the pupil; it covers the entire sclera, so the whole white part of your eye. Okay, so those are extremely expensive. And if I just dropped $1,000 on brand new scleral lenses and I was a dum-dum and didn't read the box, or somebody gave this to me, a nurse gave this to me, a doctor gave this to me, and they didn't tell me that it was going to stain my $1,000 scleral lenses, I'm going to be pissed. Pissed. Patient education is very important. Do not use this drug longer than 2 days. Why? It masks the symptoms. If you are still experiencing UTI symptoms after 2 days, something's wrong. Your antibiotic is not adequate enough, or you're not getting treated fast enough. Urosepsis is a very real thing that can kill you. Okay? So you do not want to use this for more than 2 days because you don't want to mask the symptoms. If you have symptoms, you need to tell your provider, hey, I've been on these antibiotics for 24 hours and I'm still having painful and frequent urination. It's not getting better. It's been 48 hours. It's not getting better. Okay? Not good. The only thing I need you to know, this is super important. You got 2 more minutes. Elmeron, very, 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 very important. Okay. Yes, this is a bladder protectant, but it has a heparin-like compound that has anticoagulant and fibrinolytic effects.
We're still asking me a lot wrong here.
You're good. So, if it has a heparin-like effect, anticoagulant and fibrinolytic effects, what am I worried about? Bleeding. What are my signs of bleeding? Bruising. Dark stools. Coffee ground emesis. Petechiae.
If it's new active bright red blood, but
Yeah, any bright red blood. I feel like I'm missing. Oh, bleeding gums. Okay. So yes, it prevents irritating solutes in the urine from reaching the bladder wall. It can decrease pain and discomfort of interstitial cystitis. It is very, very important that you know about the heparin-like ability. Okay. Contraindications involve any condition that involves increased risk of bleeding. History of heparin-induced thrombocytopenia, which is called HIT, H-I-T. Thrombocytopenia, decrease in the platelets. You want to be cautious with the liver and the spleen because, first of all, it gets metabolized in the liver. And guess who houses a lot of red blood cells? The spleen. It also holds some of our platelets. Okay? It also has a lot to do with bleeding. So, adverse effects include bleeding that may progress to hemorrhage, and drug-to-drug interactions. I'm not mixing it with my anticoagulants. Aspirin, NSAIDs, because NSAIDs increase the risk of bleeding. All right, well, I guess I'll finish this on Thursday. Thank you. Questions? I'll be better on Thursday. My foot is cramping so bad right now because those stupid shoes.
No, you don't feel like it, but you did.
Ugh. I am my own worst enemy.
We all are.
Oh.
This class is
Give yourself grace.
Yes, it is.
Yes, it is.
What the hell was that?
You know what days you usually do that group thing on?
It just depends on when I can fit it in.
Yeah, I'm just
Are we dismissed?
Yes, ma'am.
Thank you, Miss Simmons.
Anybody
a
have
good day.
any? Thank you. Anybody have any questions?
Yeah, just text me what you want.
Okay,
I do.
go ahead.
So I know someone asked, but in my group chat, we just kind of want some clarification.
Mm-hmm.
So don't yell at me. I'm taking one for the team.
When do I yell?
When do I?
Yeah.
I guess that was a little aggressive.
That was just.
So
Go ahead.
you said when someone asked about do you use generic or the
Brand names.
What brand name?
Yeah.
It wasn't kind of clarified which one you do use on exams. Do you use
So
both?
I actually try to include both, but I do know that the NCLEX is strictly brand names. But I
Right.
usually
'Cause
try to
usually-
include both.
Because you do the generic and then in quotations you do the brand name as well.
Correct.
Okay. So say
Because I want you to be able to recognize both. But I
Right.
don't want you to only be able to recognize the brand because then you won't be able to recognize it on the NCLEX. Let me stop sharing the screen.
Makes sense.
Do you mean to say generic for NCLEX? Because I think that's what you wanted to say.
Say that again.
Yeah, I think you meant to say NCLEX uses generic, not brand names.
I thought that's what I did say. NCLEX uses generic names
Okay.
only. Yeah,
Mhm.
I thought that's what I said. I'm sorry.
Okay.
Does anybody have any other questions? Paige, are you still on? You emailed me, right? About after class? Was that you?
Yes.
Okay. Do you want to, we'll leave here and then we'll come back so it's not recorded?
Yeah, that's fine.
Okay.
One more thing, Miss Simmons.
Yeah.
2 weeks ago, my little cousin was murdered
Oh my.
out towards Toledo, and the kid who did it, his trial is starting this week.
Uh-huh.
And my mom is going to be with my aunt and uncle and stuff, but she doesn't want to drive that far by herself. I did offer to drive her and drop her off at my aunt's house in Toledo. So Thursday morning we're leaving here about 5:36 so I can get her. So on my way home, I'll have you up, but I'm gonna be driving home from there.
Okay. Please be very careful.
Yeah.
First of all, don't be looking at your screen. You don't need to be. And if you want to just miss, I will have the recording. I mean, I know you don't want to miss, but I
Yeah.
mean, that sounds like a really emotional situation and
Yeah.
stressful. And I also don't want you like getting in a wreck.
Okay.
Okay.
So,
So
all right.
use your best judgment. You know, I'm not gonna like beat you up if you miss class.
Sure about that?
Maybe. I think so.
I wanted to tell you because once I go get these kids, my life is gonna be a little hectic. So
Yeah.
okay.
Okay.
Thank
Anybody
you.
else have any questions before we get off? Just got
No, ma'am,
silence.
thank you.
Okay. All right. Paige, I'm gonna end this and then I'll reopen it when I get my office. Okay.